Good morning, everyone. As I'm sure you can tell, my name is not Umair Ahmad. Unfortunately, he was not able to make it this morning for our presentation. My name is Priya Roy. I'm a third-year general cardiology fellow at the Ohio State University Wexner Medical Center, and I'm one of the members of Dr. Ahmad's research team, so I'll be stepping in on his behalf and sort of sharing our work with you. Our study is entitled Disparities in the Use of Atherectomy and Intravascular Lithotripsy for Percutaneous Coronary Intervention. I'm particularly excited to be here sharing our work with you this morning because our study is set to be published in this month's issue of SCAI, which comes out today, so it's cool to be able to share a little sneak preview of our work with all of you. In terms of disclosures, like everyone who's presenting this morning, our work was in large part supported by an early career research grant co-funded by SCAI and Shockwave Medical. We have no other financial disclosures. So I'll just sort of hop right into things here. It's in our current political landscape, it's not particularly popular to talk about things like disparities or inequities in healthcare access or outcomes, but I think it's important that we do so, if for no other reason than that it's, once you start looking at this data, it's really hard to look away. It's very well documented in the medical literature that there's this inverse relationship that exists between a patient's socioeconomic status and their cardiovascular risk, such that patients from lower socioeconomic strata are at an increased risk of developing cardiovascular disease and coronary artery disease included in that. And not only that, but these patients also tend to have more barriers to access to care for those conditions. This is not a new phenomenon. It's not a phenomenon that interventional cardiology as a field is immune from. Researchers back in the 1990s were seeing income disparities in the use of angiography. At that time in the 1990s, they were saying if you lived in a low-income neighborhood, you were less likely at that time to receive an angiogram within 6 months after an acute MI. If you received an angiogram, you were waiting longer for it, and your one-year adjusted mortality rate tended to be higher. And unfortunately, we've seen this pattern sort of reproduced and redemonstrated over the years, even as our medical practice and systems have changed. More recently, in 2022, so this study was published in the Journal of the American Heart Association, found a similar sort of trend where patients who had lower annual household incomes were less likely to receive angiography and PCI after an acute NSTEMI. And not only were there disparities across the socioeconomic gradient, but there were racial disparities as well that they found in the receipt of angiography and revascularization. And so this sort of led us to the question of like, well, what's next? What comes after the angiogram? And in particular, we were interested in questions around the use of calcium modification tools like atherectomy and IVL. We wanted to know, we can acknowledge that there are disparities that exist that alter the utilization or access to things like angiography, but once a patient has overcome those barriers by whatever means, they found themselves in a cath lab, you've identified that they have obstructive coronary disease, do these same trends exist to the extent that you see differential treatment in their severely calcific coronary disease? And if these differences exist across socioeconomic strata, we were interested in how significant are those differences and what are some of the factors that maybe contribute or don't contribute to those differences. So in order to study socioeconomic status, you have to pick a metric for how you're going to measure this. There are a lot in the literature. The one that we chose to use is one that's well validated. It's known as the Social Deprivation Index, or SDI. This is a pretty robust composite measure of area-level social deprivation, and it's derived from multiple household and demographic characteristics that are found on the US Census. So this is an area-level metric, so if you have somebody's zip code, you can figure out what their SDI is, and really there's 7 key characteristics that make up the SDI. You look in that zip code at the percentage of individuals living in poverty, those with less than 12 years education, those living in single-parent households, rental housing, overcrowded housing, households without access to a car, and then there's unemployment data that's incorporated as well. And once you combine all these characteristics, you can calculate an SDI, and you get a number. That number is between 0 and 100, with higher SDI values indicating a higher extent of social deprivation. So our study was a retrospective registry study. We used the NCDR CAP PCI registry, which is the largest repository of PCI data in the country. And we focused on this 5-year period from 2018 to 2023, really straddling that time when shockwave IVL became FDA approved for use in the treatment of calcific coronary disease. We were able in the registry to identify which patients had severely calcific lesions, and then we excluded patients if they were missing data that was important for evaluating socioeconomic factors. So if they were missing zip code data, if they were missing data on race, or if there were sites that were poor reporters of zip code data, so we couldn't calculate SDIs for those patients consistently, we excluded those individuals from our study cohort. From there, we could identify which patients underwent atherectomy and IVL or IVL for their procedure, and then to evaluate this relationship between the use of atherectomy or IVL across the spectrum of SDI or social deprivation. We used hierarchical regression modeling. We have an unadjusted model that I'll share with you, and then we adjusted as well for potential mediators or confounders that we had sort of predetermined. So this is just sort of a graphical representation of this, of how our study cohort was built. In that 5-year period, in terms of all comers for PCI, there's about 4 million patients. Once you pull out those patients who have calcified disease and you start excluding patients who have missing data, you end up with a study cohort of just over 300,000 patients. So our study cohort was comprised of these 310,000 some patients at a mean age of 70 to 71 years of age. 69% of these patients were male, 82% were white, and the mean SDI was around 47. In total, about 33% or a third of these patients ended up undergoing atherectomy or IVL. This is a really busy table. It's really just meant to kind of show all these different characteristics about our study cohort. Across that top row is the SDI score, segregated into quartiles, and the first quartile over on the left is these are, again, the folks who have the least amount of social deprivation. And then all the way on the right side, at the highest quartile, are folks who have the highest degrees of social deprivation. And this is a really busy table, so I've highlighted a couple of trends that can sort of stick out to us sort of off the bat. If you look at individuals in the highest quartiles of social deprivation, they tended to present younger for PCI. They were less likely to be white. They were more likely to have cardiovascular comorbidities along with their coronary disease, including hypertension, smoking, diabetes, chronic kidney disease, and they were more likely to present acutely as a STEMI, an NSTEMI, or in shock. We also looked at lesion characteristics across the spectrum of SDI. And interestingly, individuals in the highest degrees of social deprivation were less likely to have high complex lesions, so defined as ACC type C lesions. They were less likely to have bifurcation lesions as well. So then we get into our regression modeling, and just to sort of orient you to this, on the left side we have our SDI quartiles for comparison, where we compare all of our quartiles of SDI to the folks who have the lowest amount of social deprivation as our reference point. In the middle there's the odds ratio of the use of atherectomy or IVL, and then on the right is our p-value for significance with a cutoff here for statistical significance of less than 0.05. And you can see even in this adjusted model there's this inverse sort of graded relationship here, where patients with the higher levels of social deprivation are less likely to receive atherectomy or IVL. In this case, they're about 15% less likely to receive those technologies in the course of their PCI. And then, again, we adjusted for a number of characteristics, mediators and potential confounders for these effects. We focused on kind of 3 categories of potential characteristics to modify or adjust our model for. So they're patient-specific factors, like their age, their sex, their medical comorbidities, lesion-specific factors, mostly related to lesion complexity, and then PCI indication as well. And you can see, there's some attenuation of this effect, but the trend still holds. The patients with the highest levels of social deprivation, people in that highest quartile of SDI, are in this case about 8% less likely to receive atherectomy or IVL compared to individuals who are less socially deprived. Our results are congruent with other work that's in this field, looking at the effects of a relationship between socioeconomic status and coronary revascularization and intervention tools. In particular, even studies within the last year. There was one published in SCAI earlier in 2024 that found similar sort of income disparities in the use of intravascular imaging during PCI. And I think that really brings up this question in our minds of how much of this trend is being driven by access to these technologies at the level of hospital systems or individual cath labs. you know, the hierarchical regression modeling that we used in our analysis in some ways can sort of adjust for or account for these site level variances, but probably doesn't mitigate that effect entirely. And so you wonder if the cost associated with acquiring and maintaining these devices and technologies in our labs maybe accounts or explains some of the area level differences that we saw in our data. Hopefully, as system practices change, as compensation models continue to evolve around the use of atherectomy and IVL, we'll see sort of broader use or incentivized use of these devices. And you know, if that's the thing that's driving this effect, hopefully what we'll see is more uniform use of these devices across the socioeconomic strata. To that effect, sort of some of our future work will include looking at sort of the geographic distribution of atherectomy and IVL use across the country, and getting a little bit more granular data about how that has changed over time and how that has affected use across the socioeconomic spectrum. In terms of acknowledgements, of course, I'd like to thank Dr. Ahmad for leading our research team, as well as our research group across Fairfield Medical Center, OSU, Mount Sinai, and the folks at Mid-America Heart Institute, and then, of course, our funders at Shockwave and at SCAI. And in particular, I just wanted to thank Justine for all of her help in the last year, very patiently helping us to navigate the funding and publication process. So I'm happy to take any questions you may have.
That is a very impressive presentation, especially by a third-year cardiology fellow. So congratulations and keep up the great work. One of the questions I had was, and you touched upon it, the data is being presented primarily by the zip codes of where the patients reside. Did you check or cross-reference that against the zip codes of where they received their intervention?
Yeah, so that is something we did not do, and I think it's going to be important in future work to answer this question of where are people getting interventions, you know, and does the type of center that they're going to help predict how likely it is that they're going to receive these technologies.
Well, as a Buckeye myself, so congratulations, really great presentation. You know, that is interesting. I mean, it's hard to avoid the geographic fallacy when you do these deprivation studies using zip codes, but it is kind of interesting that even after accounting for clustering, there's less use of these technologies. You know, I was pretty much convinced that when IVL came out commercially that it was going to dry up our atherectomy referral business, because I thought that everyone in the spoke hospitals was going to use IVL, and we're just not going to see those referrals. It sounds like that's actually not the case, which is kind of interesting. And it does make me wonder, you know, how the sort of diffusion of technology, you know, kind of affects overall practice patterns. You know, it's hard, obviously, to get outcomes from NCDR because it's only in hospital. But I would have to think that this is likely going to affect what's going to happen in terms of restenosis and repeat procedures as well. Do you have any comments on that?
I mean, I would imagine the same thing. We had sort of the same question, but I think the data set that we used, as you sort of alluded to, the NCDR registry data set doesn't really allow us to get that granular data and sort of follow up on these patients. But I agree, you know, this is sort of an evolving field, it seems. You know, IVL kind of came on the market in the early 2020s. And even in the last few years, we've sort of changed our guidance on which centers are sort of recommended to use it. You know, now we're using IVL and atherectomy in non-surgical centers. And so I think this is just going to be something that continues to change. And in some ways, it's good. In other ways, it makes it harder to study. Like, these sort of time series considerations are a little bit more complex. But I'm hopeful that that means that, you know, there's going to be broader use of IVL and atherectomy, and more people can benefit.
Yeah, I do think that what Sunil brought up is really interesting, that, you know, I live in North Carolina, Sunil used to be in North Carolina, and, you know, we have a combination of very urban and very rural areas, and the referral patterns for advanced procedures, things like atherectomy, you know, oftentimes result in people coming a long way for a procedure, very different probably to where Sunil is now, you know, in New York City, where there are pockets of geography with different, you know, social deprivation indices, but the travel distance or the resource the distance to a well-resourced hospital is a little bit different. So I do think that it would be very interesting to see how far these patients are traveling, or what is the zip code that they're going to get these procedures. But overall, a really interesting analysis.
Yeah, I think that's something that's come up in conversation among our group sort of repeatedly. I think everyone's sort of interested in digging a little bit deeper and figuring out, like, where are these patients living? How is that different from where they're actually getting these procedures done? And is that maybe something that's driving either access or outcomes?
Just a brief comment. Congratulations. It's part of the larger cardiovascular findings, I think, about access to care. At these sessions a year ago, at a previous award winner, the presentation was around peripheral arterial disease, zip codes, access to care, and the very higher amputation rate depending on what your access to care was. So this is clearly a phenomenon across medicine and cardiovascular medicine, particularly. It'd be interesting to correlate some of those findings from your study with other kinds of procedures offered, but very clearly an important finding.
Thank you.
Great. Thank you very much.